A wonderful, wonderful. It's Earl Abastic with the Linen Sisters. This is a Puscast covering the infectious disease literature from the first 2 weeks of August in the year 2018. References are available at edgydoc.com, home of my stagnant multimedia empire. Regular listeners, and I pity the poor fools, know the rest of the spiel, so let's move on to the literature, shall we? We'll start with cytomegalovirus, and people do shed CMV. Evidently, they've even looked at astronauts shedding during space flights, but no one has looked at incidents of shedding of CMV until now. This study looked at CMV in the urine of over 6,800 people, and the overall prevalence was 3.8%. But the younger you were, the more likely you were to shed, with youngsters having about a 10% shedding rate. And this bears towards the transmission of CMV in populations where a lot of it's being shed in people, and gives validity to the fact that I always stand at least 5 feet away from urinals. Another virus I've never heard of, and again, no pronunciation guide, drives me nuts, but you're used to me complaining about that. It's spelled Madariaga. Madariaga virus? I don't know. I need a pronunciation guide. Drives me nuts. Anyway, I'll call it the MAD-V, as they do in the article, because they probably don't know how to pronounce it. You have the alpha viri, which includes Eastern equine encephalitis, which in North America is a single genetic lineage. In South America, it's a different lineage, and they call it the MAD-V virus, and it occasionally causes encephalitis in people, albeit rarely, or at least in humans. It is a big problem in horses. There's a brief report in Clinical Infectious Diseases of a child with a nonspecific febrile illness who turned out to have the unpronounceable MAD-V virus as the etiology. So the purpose of this article is to point out that the MAD-V virus is distinct from both Eastern equine encephalitis virus, found in North America, and Venezuelan equine encephalitis virus, which is found in, Venezuela. The symptoms in the child were thought to be due to Zika virus, or maybe dengue or chikungunya, but it turned out to be the MAD-V virus. It is also, they note, spread by mosquitoes, and may have reservoirs in bat or rural populations. So another differentiation into the various alpha viruses that can cause diseases in human beings. And again, my plea to clinical infectious diseases and their ilk, pronunciation guides. Of course, there's not a chance in hell any of the editors of CID or JID listen to this podcast, so I suppose I should write them an email. A couple of HIV-related papers. One is a study out of Copenhagen that looks at a specific phenotype of HIV patients who have, quote, abdominal obesity associated with proatherogenic metabolic factors, including LDL-C, hypertension, and hypertriglyceridemia. And fat redistribution of HIV, besides causing sleep apnea, as we talked about in the last podcast, is also associated with an atherogenic phenotype that is detrimental to the long-term cardiovascular health of HIV patients. And again, part of the reason I'm glad I no longer am involved in HIV care, because I don't find lipids and hypertension and diabetes to be the least bit interesting. Although it is amazing what they do with medications for that disease. There's a monoclonal antibody called, I'm probably mispronouncing this one too, the New England Journal of Medicine needs a pronunciation guide, Ibalizumab, Ibalizumab, and it's a really cool monoclonal antibody. It, quote, binds CD4 extracellular domain 2, thereby preventing conformational changes in the CD4 HIV envelope glycoprotein complex that are essential for viral entry. Now that's a pretty nifty mechanism for a drug to work. And is it effective? Well, in a study, phase 3, of HIV patients who had advanced disease, they found that it had, quote, significant antiviral activity for a 25-week study. And not unsurprisingly, they found emergence of decreased efficacy in patients who had virologic failure. Resistance, as always, to misquote the Borg is inevitable. But you gotta admit, that's a pretty clever way of messing with HIV. I'm always deeply impressed at the things people can come up with. Everything, it seems, but a damn pronunciation guide. Mumps. There's a word I can pronounce. Parotitis. There's another one. Usually when you think of viral parotitis, you think of mumps. However, there are a pair of articles in CID this month, one of which suggests that influenza, especially influenza A, is associated with influenza, and another looked at the etiology of parotitis during influenza season and suggested that both mumps and HSV could be causes of parotitis. There's a nice accompanying editorial on the problematic issue that's always the case in infectious diseases as to when association is causation. And they start with a quote from the ever-popular Sir Austin Bradford Hill. And if you are unaware of Hill's criteria for helping prove that association is causation, I wrote an article about it over at Science-Based Medicine once upon a time. And the editorial concludes, after properly noting the skepticism that should come along with these studies, quote, "These studies strongly suggest that parotitis can be added to the long list of syndromes caused by influenza." A podcast or two back, I talked about a case report of a rickettsia illness being successfully treated with rifampin. Well, scrub typhus is due to Orientia tsutsugamushi, and doxycycline is the usual treatment of choice. In Thailand, evidently, there is some doxycycline resistance of scrub typhus. So in this study out of Korea, they compared outcomes of doxycycline versus rifampin in patients with scrub typhus and found them to be equivalent in resolution of disease and equal in terms of side effects. So if for some reason you can't give doxycycline to your Tsutsugamushi fever patient, well, you got rifampin as a backup. So as a rule, you do not want to give prophylactic doxycycline for Lyme disease if the tick has been feeding for less than 36 hours. But it's very rare that the tick has a iWatch that they use to time their feeding. So what can you use? Well, there's this thing called the Scuttle Index. It is, quote, defined as the body length of the tick divided by the width of the scutum. Because during feeding the body length increases while the width of the scutum remains constant, the Scuttle Index provides a measurement of the degree of blood engorgement of the tick, which has been demonstrated to directly correlate with the duration of tick feeding. Of course, I don't know what the hell a scutum is, so I look it up. It's a Roman shield, and evidently each tick has its own unique scutum or shield. Who knew? But annoyingly, they don't tell you what the cutoff for a 36-hour Scuttle Index would be, nor is the reference available for me from the reference in the article that points to the Scuttle Index. But they concluded that based on the Scuttle Index, when it could be calculated, that 40% of prophylactic antibiotics were given unnecessarily. Fortunately, I do not live in Lyme country, but for those of you who do, peer at your tick under a microscope, measure the scuttle and the length, and if you can find what the cutoff could be, more power to you. Lyme in Europe is not the same as Lyme in America, so the study may not extrapolate to the United States. But out of Slovakia, they looked at patients with either a single erythema migrans lesion or multiple erythema migrans lesions, and they were randomized to receive either doxycycline for 2 weeks or ceftriaxone for 2 weeks. And while the patients with multiple Lyme lesions, skin lesions, were slower to get better, at the end of a year, the two groups were comparable in terms of outcome, with about 6% of patients having persisting symptoms. But it looks like it takes a good, or maybe not so good, year to completely recover from your initial Lyme infection in Europe. Although, as noted in a response in Medscape, it's difficult to know based on the methodology whether or not any of these patients truly had a post-treatment Lyme syndrome based on the methodologies that looked at the patient's quality of life. There's an article out of Algiers that looks at the presence of leptospirosis in dogs, and they found that 4.8% of dog urine had PCR positive for leptospirosis. And you may say to yourself, well, I don't care. I don't practice in Algiers. It's important to remember that leptospirosis is worldwide in dogs, and there are hotspots in the United States of dog leptospirosis, especially the Midwest, East, and Southwest. I don't go around peeing in my neighbors' yards, but their dogs certainly go around peeing in mine, and it's important to remember they may be giving you and yours an exposure to leptospirosis. Here in the great state of Oregon, over a 5-year period, they found 72 cases of leptospirosis in dogs, associated, not unsurprisingly, with rainfall, and the dog subsequently being exposed to water, just like human beings. But your dog, it's a potential vector for leptospirosis. If there is a competition to become the first bacteria common pathogen to become pan-resistant to antibiotics, it may be gonorrhea. There's a new drug in testing, probably going to mispronounce this one, gepotidacin, Gepotidacin. What is that, you might ask? It's a bacterial type 2 topoisomerase inhibitor that selectively inhibits DNA replication by interacting in a unique way on the GYRA subunit of the bacterial DNA gyrase and the PAR-C subunit of bacterial topoisomerase 4. And in this phase 2 study, it cured more than 95% of patients with gonorrhea with a single oral dose. The big bummer, 2 of the 3 failures already had high-level resistance to the antibiotic. So when it becomes available, it will likely be useful for a short period of time. And then the development of resistance will preclude its usual use. The BS of the p-value. As I've talked about before, a p of 0.05 is probably nothing. A p of 0.01 is probably nothing. You probably need a 0.005 to truly have a significant, clinically relevant result. I say this because this study looked at acute sinusitis and compared high-dose amoxiclavulanate with standard dose amoxiclavulanate. And they say in the trial that, quote, adults who are clinically diagnosed with acute bacterial sinusitis were more likely to improve rapidly when treated with high dose than standard dose, but they were also more likely to have severe diarrhea. And I don't think that conclusion is supported in the article itself. When you go look, at no point is there any real statistically significant difference between the two groups at any time point, and everybody is the same at 10 days. Also, for the SNOT score, which is how you measure symptoms in sinusitis, there was no difference. The only thing that was different is the patient self-reported, "I feel better," which they thought was more clinically relevant. Color me skeptical. My reading suggests no difference in the treatment outcomes, and I don't think patients really got better faster, although they did get more diarrhea on the higher dose. And since everybody is the same at 10 days, why go with more complications? Although I am sure this will be used to sell high-dose amoxicillin clavulanate. And as an aside, I always look at the funding of papers like these, and it is surprisingly obtuse. It says in the funding statement, quote, "The study was funded by contributions from the corresponding author." And when you go up and looking at the corresponding author, it says he had funding acquisition. He paid out of pocket to run this study? I don't know. That seems really weird. It just doesn't seem like a transparent discussion of the funding, especially what I read is a negative study that's purported to be a positive study. Studies on the risk factors for mortality for various diseases I tend to avoid talking about because although they are interesting, they rarely apply to an individual patient. So maybe being, say, obese is associated with more mortality. I can't change my patient's body habitus. So it's always interesting but not helpful in individuals. However, this study looked at predictors of mortality in recurrent C. difficile. And there was a modifiable risk in this study, and that was use of PPIs. And there have been other studies to show that PPIs increase your risk for C. difficile. So I think this is more fuel for the fire that when you have a patient with C. difficile, you should get rid of the PPI. The other risks were treatment with antibiotics and the underlying comorbidities, but you really can't change either of those most of the time. Human microbiome studies are always interesting, although they're somewhat like the weather. Everybody complains about it, but nobody does anything to change it. There are 3 interesting studies out, though, this month. One shows that in kids who have ALL, the composition of their gut microbiome predicts febrile neutropenic episodes, especially if they have a relative abundance of proteobacteria. And if they shift their gut microbacteria to Enterococciaceae, how do you pronounce these things? Enterococciaceae or Streptococciaceae, Streptococciaceae, they're more likely to get an infection. Although alterations in the gut microbiome are not necessarily bad. In a study out of Africa of kids who were receiving azithromycin, which they were giving in the community, they found an alteration in the gut microbiome across all the children, but in this case it was associated with improved childhood mortality. And then lastly, and the gut microbiome also is associated with susceptibility to getting Vibrio cholera infections. In terms of all the above, currently nothing you can do to change that gut microbiome for the better or for the worse, but it's still interesting on the interactions of how your endogenous flora alters your susceptibility to various disease states. This study just confirms what we basically already know about treatment of prosthetic joint infections. 1, the longer you treat them, the better the outcome. 2, rifampin is key to having a good outcome. And 3, smoking is an important risk factor for failure. But what was important, it didn't matter when the infection started, whether it was early or late, you got the same outcomes as long as you treated it for a long time and you had rifampin as part of your cocktail. Here's one of the things that really fries my bacon. Now, classically, an aspiration pneumonia was somebody with poor dentition, seizures, heroin, alcoholic, who loses consciousness and aspirates oral flora with rotten teeth into the airway. And they usually present with months of symptoms, a lung abscess with without empyema, and remarkably foul breath. Those are called an aspiration pneumonia. At some point in the last 10 or 15 years, an aspiration event has been treated like an aspiration pneumonia, despite the fact that, for example, you can't find any studies to support the notion that they're anaerobes in acute aspiration events. But that doesn't seem to stop anybody from putting on metronidazole, despite the fact that for community-acquired, hospital-acquired, and ventilator-associated pneumonias, when they've looked for the presence of anaerobes, they never, ever find them. This retrospective study, though, looked at the benefit of prophylactic antimicrobials for an acute aspiration pneumonitis. And guess what? It found that antibiotics, quote, did not offer clinical benefit, but did generate antibiotic selective pressures that results in the need for escalation of antibiotic therapy among those who go on to develop pneumonia. Although we all know that it's clinically difficult to distinguish between an acute aspiration event and what you find on chest x-ray and an actual pneumonia. But at least they read the literature in this particular study, because none of these patients were put on anti-anaerobic drugs. It was usually third-generation cephalosporins. So not only is an aspiration event not the same as an aspiration pneumonia, but aspiration events most of the time don't require antibiotics. I love studies that confirm my fundamental bias. This was a study out of Japan. It was retrospective, bummer there, that looked at the outcomes of treatment of MRSA infections based upon what they were treated with. The majority got vancomycin, 71%. 16% got linezolid, 9% got teicoplanin, we don't have that in the United States, and a mere 5% got daptomycin. But vancomycin was associated with the lowest survival rate, although the P was only 0.067, but was particularly ineffective in patients with pneumonia, and there the P was 0.034. So, not statistically significant, really. But generally speaking, I'm increasingly inclined to think vancomycin is a drug of historical interest. Although, based on the literature, you can't really say that other drugs are superior. I don't know. I think vancomycin needs to go into the dustbin of history. And like most people, I adore a study that confirms my pre existing biases. About 10-15 years ago, the waters of the Pacific Northwest became warm enough that Vibrio replication was supported in oysters, and as a result, there were outbreaks of Vibrio infections in people who consumed raw oysters. Now, it's happening in Norway as well. The water is now 4 degrees higher than average, and as a result, they're getting Vibrio outbreaks in Norway. Good thing that global warming is a Chinese hoax and we don't have to worry about it. Another study to show that aspergillus is an important infectious complication of influenza. In immunocompetent patients, the incidence was 32%, whereas in the non-incompetent patient it was 14%, but still getting aspergillus as a complication of your influenza was associated with increased mortality. We are out of flu season this year, but something to keep in mind in the yearly outbreaks of flu that we have. Most of you who listen to this know that Chagas is endemic in the United States, but so is, at least in some parts, leishmaniasis. Predominantly in Texas, they have found 41 cases of leishmaniasis in people who have never traveled in the prior decade to places where leishmania is endemic, and it was always Leishmania mexicana. It's probably another disease coming north with the mythical global warming. The rat lungworm. It causes infections of the brain. It's found in snails and slugs. And there have been 12 cases in the United States that were associated with CSF pleocytosis, eosinophilia, and meningitis. The biggest risk being eating raw vegetables from the garden, which presumptively have snail/slug poop on it. And 2 people actually ate raw snails. Not my kind of sushi. And while classically the disease occurs in Asia and in the Pacific Islands, there are risks in the United States if you eat the wrong sort of snail/slug poop. And that brings this particular Puscast to a close on a call weekend for me. There is, by the way, a review of encephalitis in the New England Journal of Medicine that is quite nice. Otherwise, references are available online at edudoc.com, home of my stagnant multimedia empire of books, blogs, podcasts, and apps. Otherwise, not much to tell you, except, as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation. Goodbye.